Thank you so much. Good morning, everybody. I think the previous two speakers have basically given us the two sides of the coin, right? One is the smart hospitals, the other one is LLMs. Today, I really want to make sure that my goal is to connect these two. First, as we started with your question, I would like to take a stab at it. But I think when you look at this, we started digitizing, right? We started digitizing records, imaging, workflows, and the digitizing has happened. Right now, think about it. The technology, alone doesn't. Now there's AI. What do we do, right? So that's the crux of my. Okay, I have advanced my slides. Okay, this is my slide. So basically, earlier the talks were about smart hospital and AI, right? But now let's make sure that, there's a smart hospital, but there's the model. But in my opinion, there's 90% of the work that has to be done by people and process, and that people are sitting right in this hall. There are AI engineers, there are doctors and healthcare workers sitting in here. That has to happen. So when you look at this, the crux of my talk is really this. The algorithm, the models that we talked about, hallucination, the models and all, in my opinion, that's only 10% of the work. If we think that we have great models, that's great, but we haven't even started yet. Then there comes to 20%, which is your data layer, the data pipelines, and then your technology stack that basically addresses the backbone. That is still 20% of it. The remaining 70 is the people, process, trust, governance, compliance, and workflow changes. Think about it. You have an awesome model. You use the model, because I have seen far too many times that using a great model, and if you don't change your workflow, nothing changes. So make sure that, so my talk is going to focus on it, but let's look at how we got here, right? Healthcare has evolved. I'm sure in this room, everybody has gone through these phases. First it was the monolithic hospital, primitive, but healthcare was delivered. Then the service-oriented architecture, then the cloud native. Now we have AI infused. But think about the first three boxes as creating data, storing data, and processing data. The last box is where the key thing is, right? Where AI can act on the data where the data is produced, which means it can act at the source. It can act, it can make decisions, it can make a lot of things. So what does that mean, right? The hospitals, the current operating models that we have, there has to be a big shift in mindset, in a lot of thinking that we should do, right? From this shift in this technology. So the key aspect is three verbs, in my opinion, for this talk, if you remember. It's no longer collecting data, storing data, processing data. It's about, do I have something that can reason? Do I have something that can collaborate with the physicians and the AI agents? Can the actions taken, the act, is it trustworthy? Can I trust the action that is taken? Those are the key things, right? So generating text, summarizing text is great, but when you go to a bedside care and when you go into a radiology, that's not good enough. So think about reason, collab, and act. So when you think you're doing an AI project, make sure that you have these things baked into it. So how do hospitals make it, right? So I just wanted to give you this blueprint of an intelligent hospital. Most of the hospitals have it, and they do think they have it. It starts with the bottom, right? You have the bottom foundation, which is your hospital information systems, EHR, and all the foundational systems. On top of it is your unified healthcare layer, which is the data layer. When you talk about AI, people start jumping to layer one. They talk about equipping the patients with something really good that they can start using. But then they're missing the middle layer. The middle layer is where we should be thinking about it, right? Because the middle layer has the safety, it has compliance, it has auditability, it has human oversight. That's the key layer that you should be thinking about it. So let's look at the type of agents, right? Because I'm going to end up the thing saying, how do you do that? How do you get there? What does a physician should do now? What does a AI engineer should do now? So when you look at it, in my opinion, the fourth layer, agents, just make it simple, remove the jargon, and make it sure that think about this three layers. Layer one is an agent that gives you insights. The summarization part, the right now things are really at that level. Next is if you have 2 or 3 agents that can derive insights, we stitch them together, it becomes a workflow. That's layer 2. Now think about deploying this workflow in multiple departments in a hospital and having an orchestration layer on top of it that can orchestrate across from intake, from patient intake to pre-op to during operation to post-op, and then billing and charging. So that's orchestration happens across the departments, right? That's tier 3. So let's look at each one of them. The first one, as I said, it basically gives you the summarization. It can be used at multiple places. It reduces documentation burden and saves clinician the time. One of the biggest problems that I have seen being in this field is clinicians not having enough time to take care of their patients. This can give you that 10% of your time back by doing the mundane work that they do. The second one is tier 2. These are basically, they can do structured tasks. If you combine 2 tier 1 agents, you are in tier 2, right? You basically get into there. But every action should be traceable, everything should be actionable, so that's where governance comes into place. You need to have a governance that takes care of it, the middle layer that I talked about. And this is where the orchestration layer is about, right? When you stitch all this into 3 or 4, it becomes an orchestration layer. So you may say, okay, Bernie, I understand all this, but where do we start? In my opinion, internal medicine is the best place to start as a starting point, right? Because there is high patient volume. It creates immediate value, in my opinion, based on my experience. Think about ambient scribes, think about chart summarizations, medication safety checks, and things like that. It can be a good start. So L1 is very dominant here. The L1 type of agents is very dominant. L2 and L3 can be selective, and progression should happen, and improvement should happen. And then next comes to critical care, right? This is where time matters, speed matters. Any hallucination is going to have an impact on the patient. So we have to make sure that the recommendation has used a protocol that's been defined at the behind in the governance layer. So governance is not optional in here in ICU, but I see a mix of L2 and L3, which means this is a bit advanced adoption of AI in there. L1 is fine. You can basically use bedside telemetry to stream that data in to take some action, but L2 and L3 is very active. So next is the organ-based, right? So I didn't want to have every slide for everything, but when you look at it, cardiology or neurology or nephrology, the pattern is similar. What I mean is the risk is high. You need to have a lot of governance. Fast decision making is key. The goal is not replacing the specialist, but giving them what they need at the point of care. And then next look at oncology, right? Oncology uses all 3 agents. You have L1, L2, L3. What I mean by that is patient coming in, summarizing the case, identifying the critical trail, using genomics and support of treatment plan. Pre-op, post-op, everything is stitched together. So this will accelerate the precision medicine here, when you use this L1, L2, L3. But risk is high, governance is a key aspect of it, and human is needed, much needed in this department. When you look at the other specialties, right, it's heavily L2 and L3 as well, but you got to make sure that the goal is intervention, and predicting the outcomes is a key aspect that you should start with. So this basically brings us with 5 things that I want you to remember when you talk about an AI project. Key elements, you have trusted AI governance. If you don't have a governance board, that's the first thing that you do. You set up a governance board. And we have done this for cloud. We have done this for the other technologies and innovations. Start with a governance board and make sure that you define your compliance and what a responsible AI really means and the roles and responsibilities. That's the key aspect of it. The next is clinical grade AI safety. Hallucinations are a big thing. You got to make sure that the probabilistic is now changed to deterministic. How do you do that? We can have an offline chat. Human supervised autonomy. L2 and L3 agents are good, but humans should be in the loop. And then you need to have an intelligence platform. But let's get to this slide, right? What do doctors need to do, in order to transition into this? The key is doctors don't have to become AI engineers. they do need new skills, but they don't need to be AI engineers. The doctor basically should understand the technology and the difference between a probabilistic LLM that gives you hallucinations to deterministic, because they are the functional experts. So they make sure that this thing is validated, so they become an AI supervisor. If they want to scale, they use AI, get the things back, and they supervise what can be the intervention plan, what can be the surgery plan. So they do that. So human judgment, when you think about it, start piloting 1 or 2 use cases at an AI layer 1 level. So your role expands rather than just treating individuals. It's also managing the patient journey using the AI. That's the key thing, shift that's going to happen for the patients. But at the same point, engineers are evolving too, right? So healthcare engineers, there's a lot that started with prompting, context engineering. You have a lot of terms and a lot of speed that's happening, right? But in my opinion, focus on the bottom part of it. When you look at it, you have to earn the trust of a clinician. If you have a solution or something, you have to earn it. How do you do it? You basically have to have a governance by design. You basically have to have evaluations. It can be a code-based evaluation, or it can be a judge as an LLM that you can create that can judge what LLM said or did not say. That's the key thing. And you should have a clinical system thinking. System thinking was a big thing, but now if you really want to be in healthcare as an AI engineer, you have to have a clinical system thinking, so that you need to think like a clinician, not with the functional knowledge, but what they go through day in, day out. And the last part is observability and making sure that you're tracking everything. If somebody says, how was this patient taken? You got to go back and able to pinpoint what the LLM did, what the LLM acted, and what were the supporting data types that were given to it to make the decision. So observability is a key thing. So I think this will conclude my session, but I want to leave you with 3 things, right? Models are great, benchmarks are great, hearing all that is great. Trying to become a smart hospital is great, but there's a lot of work in between. How do you get clinicians with you, AI engineers, for a ride so that this can really be commercialized and used it across? So the first is pick a tier 1 or a layer 1 agent in your department, take bias for action, ownership, define the outcome, and define the definition of done, and kick off a project for 3 months. Try it out, learn what fails, what works. That's the key thing. Second, work with your IT department. Every clinician in this room, maybe work with your IT department to set up a governance board, and you as a clinician has a room on that board, right? Third, the data foundation. So make sure that you know where the data is. With respect to the time, I will take Q&A after the session outside. Okay, there was a beep.
Do we have time for questions?
We can have one question.
One question.
Yes.
One question, Mr. Bharanendra, if that's okay.
Yeah.
My question is, in these times of patients Googling all their symptoms and sometimes knowing more than the doctor, like asking multiple things, how do we balance this out in terms of ethical accountability in the AI system? And what about confidentiality and data privacy?
Yeah, those are key elements, right? When you look at it, the governance layer should basically handle all that. The information has been democratized, and we can come prepared as a patient to the clinician with all the information that I believe is what I know should be the treatment plan. But then the clinician has to address that in the right way with their functional knowledge. But in the governance layer, the privacy has to be baked in. The confidentiality has to be baked in as well, because that's the key element of your data layer, right? So it opens up certain threat vectors, but you have to make sure that you understand what the threat is by using the information that's freely available rather than relying on a clinician.